So this is kind of a screw up because the case is, I kind of gave away the case right there. So this is a otherwise healthy female referred from outside institution, right knee pain, feelings of patellar instability. She has a large cartilage lesion of her patella with a history of multiple prior surgeries. Her timeline is when she was 7 years old, she began having multiple lateral patellar dislocations. At 8, she had an MPFL repair. She had recurrence of lateral patellar instability at the age of 9. And at 11, at an outside institution, she had a lateral opening wedge distal femoral osteotomy with an MPFL, either reconstruction or repair, gave her moderate improvement of her symptoms for many years. She also had a TTO at some point, not knowing when. And then at age 19 to 22, she began having increased pain in her pain. They removed her lateral plate and did a diagnostic arthroscopy and found that she had a very large patellar chondral defect. So she's a healthy appearing female. She has a normal BMI. She has a significant right-sided antalgic gait. Her Baton scores is 6 out of 9. She's not incredibly hyperlax. Her coronal alignment is essentially neutral. She has 5 degrees of hyperextension, 140 degrees of flexion. Her patella enters the groove medially, however. She has 1 quadrant of lateral translation, 2 quadrants of medial translation, and demonstrates a somewhat of an inverted J sign, but she starts medially. She has medial apprehension, and she has significant patellofemoral crepitus. On the contralateral extremity, she clearly demonstrates elements of patellofemoral dysplasia with increased lateral translation, a mild J sign, equivocal apprehension on the left leg, but the left leg's not her issue. So her internal rotation of her right hip, this is a symptomatic side, is 20 degrees. Her external rotation is greater than 80. On the contralateral side, she has internal rotation greater than 60 and external rotation to 35. So these are her long leg films. She's essentially neutral. If we look at her sunrise views, we can tell there's some significant problems going on with her patellofemoral joint. On her rotational profile, she's 3 degrees retroverted on her right, and she's 20 degrees anteverted on her left. She has a trochlear depth of 0, a Caton-Descamps ratio of essentially normal of 1, and a TTTG of 6 millimeters from her prior tubercle. And you can see from that CT scan the way her right leg looks, and she's tracking medially. So she's essentially has a 20-degree external rotation deformity. She has mild distal femoral varus. So what would be your thoughts?
I would say only made in America can we be so proud of such surgery.
So the first thing.
What about her gait?
So her gait is an antalgic gait. She has audible crepitation. She does not feel stable.
But does she in toe or ex toe or neutral?
She's kind of.
You would hope that she would have an external foot progression.
Kind of externally foot
progression. Right. So
But she's also very antalgic. So it's really kind of it's a difficult gait to ascertain.
I mean, the classic retrovert femur, like a skiffy hip, is. So I did first thing I'm going to do with this case is, let's go down the panel. What would we, let me just tell you what we would do first, what we did before we kind of finally decide. So we would do a diagnostic arthroscopy first, just to stage, to see what this joint really looks like, all right? And then I can evaluate her under anesthesia to see what her patella tracking is. And then I'm going to decide definitively what's going to come later. But I need to get more information. So let's kind of go down the panel.
Is there any patellofemoral jump when she does flexion? Because there is a overlap of trochlear bone on an X-ray.
So she has a bad maltracking, medial maltracking of her patella, which you can witness in clinic when she moves her knee.
Okay. So probably she is a candidate for open trochleoplasty then removing that bump so that there is no patellofemoral maltracking or jumping of the patella out of it. If there is a tightness of quadriceps, we don't mind doing a quadriceps lengthening, Z lengthening. And the same time, you can address the mild varus at the femur with the help of closed wedge osteotomy. Or open wedge, rather.
She's subluxing
lateral
medially,
open wedge.
correct?
She's subluxing, she's tracking medially.
Medial or laterally?
Medially.
Medially.
So her
Oh,
extensor mechanism is not the problem if she's tracking on the medial side. So probably I think she's had a very large inappropriate lateral release as one of those prior surgical procedures, which has then, with an over-tensioned MPFL, which is why her whole patella has moved medially. Add to that the problems of abnormal femoral version and trochlear dysplasia and the chondral defect, and that's why she's a very unhappy person.
Yes.
Yeah.
And she probably also had a growth arrest when she had her DFO.
Yeah.
Her DFO was done way too, and that's why her trochlear dysplasia is iatrogenic.
Yeah.
Look at her other trochlea.
Yeah.
That's normal. So I've seen this a lot when people do osteotomies on young kids, and they get all funky different types of growth arrests.
Yeah.
It's a simple case.
So this is her evaluation under anesthesia. She doesn't go laterally. And you can see me on the right, she's completely out medially. She's tracking completely medial. And this is her, unfortunately for the trochleoplasty, this is what her trochlea looks like. So she's got grade 4 changes in her trochlea, and she's got grade 4 changes on her patella. This is a 70-degree scope viewing through a superior lateral portal on her right knee. And what I'm trying to show here, she's tracking, she's going medial. I can't get her out laterally.
I mean, I don't believe in patellofemoral replacement because my last name is Ranawat, but even though our hardcore believers, you still have to get her patella in the right zip code before you resurface this. Yeah. So you still have to whether derotate, trochleoplasty, and then whatever fake cartilage you want to do. Cut her MPFL, close her lateral release. It's very Dr. Iatros, the famous Greek surgeon. You got to fix all the iatrogenic injuries that were done to her.
We have any other options? All right, so iatrogenic medial patellar tracking, maltracking, medial instability from distal femoral external rotation, and she's got this an varus alignment. A history superimposed on congenital patellofemoral trochlear dysplasia and lateral patellar instability. She has grade 4 changes on her patella, grade 4 changes on her trochlea, and her medial and lateral compartments at the time of arthroscopy have some early grade 1, some grade 2, but nothing significant, no meniscus pathology. So my surgical plan was stage 1 would be a distal femoral biplanar osteotomy using, again, this is a perfect example of what I think is patient-specific instrumentation to correct her femoral malrotation and avoid loading any type of grafts that I might put in there. I would then come back later, and this patient's going to get a bipolar graft, allograft of her trochlea as well as of her patella, and she's going to get a lateralizing tubercle osteotomy. She's going to get a lateral imbrication to improve her patellar tracking. She does not need anything medially, and we're going to remove her distal femoral osteotomy plate after at her return surgery. So stage 1 is done, and then 6 months later we're going to come for stage 2. Preoperative planning, like we talked about, is key, and this is her 3D model that I also had made by our radiologists at USC. It's all done through digital, through preoperative PSI. Patient positioning, like we talked about, patient-specific instrumentation guides. This is an internal rotation osteotomy, and it's going to be a biplanar cut as well. We return to the operating room after this heals. All right, so a repeat CT scan at 5 months shows our new version. We now have a new femoral anteversion. Now she's 20, so she's essentially matching her other side, a bit elevated but not pathologic. Her TTTG is still around 6 millimeters. She's going to return to the operating room for a bipolar fresh osteochondral allografts, lateralizing tibial tubercle osteotomy, imbrication of her lateral retinaculum, and removal of that plate. So this is what was done. So it's going to be a fresh trochlea. It's going to be a shell allograft of her trochlea, and unfortunately, it's the entire undersurface of her patella is going to be replaced. She is, and this is just showing some of the steps to this surgery. I can't do all this surgery in one bang. So we're going to break these. We're going to break these in two. And then this is her follow-up X-rays, and this is her follow-up sunrise views. Now, I'm not naive to think that a bipolar in a patellofemoral joint, which is the most harsh environment, is going to live forever. But this is her after follow-up, and we're going to see what she looks like over a year after follow-up. This is her tracking on her left. This is her tracking on her right. This is her at over a year after surgery, all right? And I'll tell you what's rewarding is she wanted to show off this tattoo that she got because this was a butterfly, which represented a new life that she had been given from this graft. So this is incredibly rewarding, but I'm not under the illusion that this thing's going to last for very long. So,
Rick, can I ask you one question?
Yes, sir.
The structural allografts which has been used in clinical practice, especially the study by Alan Gross in arthroplasty, they are very short life,
Yes.
5-year, 8-year, 10-year.
Yes.
From here, where you removed the distal femur, almost the top of the distal femur, and you replace it with new allograft, what do you think the life of this allograft? Is it going to survive, stay, remain a scaffold, is going to form a cartilage, or is going to incorporate?
This is going to hopefully going to be enough that when this fails, and I'm hoping that it would be great if we get 10 years out of this, maybe 5.
No, but if you,
And when this fails, then it's going to either hopefully there'll be bone stock, that this is going to be, ultimately, this is going to be a PFJ.
yeah, but if you look at Alan Gross's data, they published in 2019, 75% survivorship, distal femoral allograft at 25 years. I think that's a big number. If 3/4 of your distal femoral osteochondral allografts are surviving for 25 years, I think that's huge data. So I think contrary to Roshan, I feel that Alan Gross's data shows that the 15-year survival rates are in excess of 80%. So if she gets 2 decades, I think she's won it.
Well, I would say if we
agree,
were talking
but
about
Alan
condyle, but this isn't
yeah.
this is a trochlea, and if it was a trochlea
Absolutely.
or a patella, this is a
But
trochlea
it's not
patella.
loaded, unlike your distal femur.
Yeah.
It's not a loaded graft, so it's going to be even better, especially since you've corrected her alignment.
Hopefully.
The Alan Grosses were truly fresh grafts, where people were pagers. This is not a fresh graft. And if anything, what the US grafts have been doing, they've been trying to increase their volume by the Missouri Mott's method,
Yeah.
and the grafts are getting older and older. And so if anything, we're seeing a higher failure rate. The problem with this graft is that there's a lot of bone. And so, but you know in a year, I mean, if you have a CAT scan X-ray, if that bone incorporates, then you're good. But if the bone doesn't incorporate, you're screwed.
Yes.
But that's a failure that you'd know within the first 6 months.
I must congratulate you. That was a wonderful case.
Excellent.
Thank you.
I'm yet to see such a good case. It was a beautiful case, the way it has remodeled and the way you've shown a wonderful results. Congratulations.
Excellent.
We need a party.
Tonight. Okay.
Okay.
Huh? Great. You have one more case?
I have one more
Yes,
weird.
please.
I have one more weird case.
Let's go for it.
Okay, so this is a weird. This is a. Save this one for last. So this is a patient, 27-year-old, otherwise healthy male, presents with a complaint of left knee pain and a left leg deformity. When he was a teenager, he underwent a rapid growth phase, and he sustained an injury to his knee and to his tibia. He doesn't really know what. He continued to grow taller, and the deformity continued to grow. Now he's 6'4", all right? So as he's gotten older, he plays basketball, he's active, but as he's getting older, he's having a harder time. He's having difficulty with ambulation. He's being unable to exercise. He has feelings of instability, ongoing pain, and decreased function. These are his long leg films, and this is his physical examination. He has this severe left tibial recurvatum deformity. And as you can see on my examination, this is not his PCL. This is all bony. So what would we, if we leave this unchecked, it's going to lead to significant early joint deterioration. And actually, if we look at his long leg films, it looks like he's got no joint, but that's really because he has a positive posterior tibial slope. So what would be your, let's go down the line. What would be your plan?
So I think this is a great case to fix by doing a slope increasing osteotomy. And this is because of anterior tibial physeal arrest. I would do this by taking off the tibial tubercle, making a sagittal bone cut, increasing the slope by putting a wedge of bone graft and putting back the tibial tuberosity so that it acts like a biological plate, couple of staples or a small plate on the side, and this person is going to be extremely happy with you.
What about the shaft?
What about the shaft? I think, see, this is something which I need to tackle at a second stage.
Mm-hmm.
You could be, really savvy and do a double level correction osteotomy, one for the slope and one for the shaft, because we have two different coras, so as to say.
Yep.
I'd probably go slow, give him back the slope that he wants, get the tibia underneath the femur by increasing the slope, and maybe if he feels that he still needs to come back for the shaft, I'll do that at the second stage.
Distal femoral flexion.
What's that?
Distal femoral flexion. The distal femur is in flexion, right?
No.
Axis is well aligned.
It's the distal femur is well aligned. This deformity is all off of the tibia.
Okay.
What was the second deformity?
So he has.
Is there a coronal deformity?
Yeah. So let's go. So let's look at this. Go back. There is a little bit of a coronal deformity. He has, if we can look at these films, he has a deformity of he's got a positive slope.
Yeah.
He had this physeal injury to his tubercle. He has a shaft, one of the coras is at the shaft, at the metaphysis, right around where the tubercle kind of is. And then he also has his fibula. So if you're going to cut that shaft, you're going to have to address that fibula too.
Yeah, but I think you could do it. I think you cut the fibula, but I would avoid the second distal deformity. I would just do everything at the way Sachin said it. I would also maybe cut the patellar tendon a little bit.
Well, if you look at so let's say if we just look at the proximal tibia and we just look at that, look where that bow is.
Yeah.
The bow, even if we give an increased posterior tibial slope, he's still going to have a recurvatum deformity of his tibia.
Yeah, so I think for planning this, we definitely need a 3D CT scan. You can't do this without 3D CT planning. And but I thought that you're going to say this is what you get.
Yeah.
Take your pick.
So again, I would go
The thing
back.
would be to do this, with a frame.
Yeah, exactly. In fact, I think that most, if I sent this to your limb lengthening service, they're going to do this guy's getting a frame. And I can tell you that this patient would not do well with a frame. And so, the operating room's not a place to think. It should be done
I can
before
tell you
the
one
case.
thing. You know who's the biggest users of our PSI now?
Those guys.
Our limb lengthening guys.
Yeah. I mean,
Yeah, because it's all about complex deformities where they can do acute, accurate corrections. The whole reason why we did frames is we couldn't do acute corrections on 3 planes.
Yeah.
So guess what? They had these things, and you would get X-rays, and it was safer, and the patients hated it.
exactly.
So I mean, this is exactly why PSI. If we're converting those guys, we're in a step in the right direction.
Oh, yeah. So we're going to listen to some music. We're going to do the iPhone, and this is what the templating showed me. So the goal was to get this straight, all right? So this is gonna be a couple definitely 4 osteotomies are gonna be done here. And just like you said, we're gonna use the tubercle to help prop open this osteotomy. And our goal is to go from the left to the right. And I could only do this with this type of these guys. In my mind, I could. And then this is our plan. And then we're going to use the tubercle to hold open that proximal osteotomy. And so the planning's done. And now we're going to go listen to music. And so this is his deformity. And if we look at, and then just stepwise, we're going to start proximally. Everything's going to be done. We got to verify all this on fluoroscopy though. And we're going to use multiple guides. We're going to do his tubercle. And so obviously this is a big case. And we're also going to work our way down from proximal down to distal. And this will be our final product here. This was what we planned preoperatively. And
Rick, were both guides medial to lateral cuts?
what's that? What's that? They were.
Both guys were medial,
Both guys were
and
medial.
both with hinge pins.
In both, yes, they were.
Yeah, so the one thing I would think, we've realized your hinge pin on the distal cut, since it's all cortical, would have to be very posterior, otherwise that will never open up.
Yeah, in fact, the posterior shaft was the hardest one. And this was the one I was worried about the absolute most as well, because of that was the hardest one to do, and it was really you're doing small puncture holes and perforating that posterior cortex to allow it to flex back.
The tibial tuberosity is with the proximal fragment or distal fragment?
I'm going to use the tuberosity to a piece of it to hold up that fragment. But you can see the tuberosity he's got a very long, essentially patellar tendon, and I'm going to try to restore a normal Catan-Descamps ratio on him. And you can see where those tubercle screws are going. And then this is him post-op. So he went from this to this. He went from this to this. And then this is, that's where see those AP screws? That's where his tubercle is right now. This is what his post-op x-rays look like. This is him at 14 weeks. So we have to go really slow on this, because this guy can't weight bear. And we're going really slow on the motion too. And I'm trying to avoid any type of open chain extension because of the amount of force and lever arm on that tubercle as well. And then this is him at 7 months. And
Is he the same guy?
This is him.
You blanked out his face on the left.
I blindfolded him in the beginning.
No, just kidding. It's a great result.
Now he's happy.
Absolutely fantastic result.
Now but this guy, I just really let this guy start weight bearing he was really weight bearing at around 5 months.
Yeah.
Because I was too afraid. I mean, we're working full motion, but he had to be protected weight bearing because obviously that so many osteotomy sites, and it's not an extremely stable construct. So.
Well, that's why you double plated it.
That's why he's got double plated. Exactly.
Yeah.
Exactly. I mean, I knew he was going to touch down, but
What about the intra-articular nail and fixation?
So that would have been another option. However, the interarticular nail would have been, in my mind, would have been very difficult to deal with the tubercle and to deal with to elevate the plateau.
Yeah, the other problem would have been, the Herzog bend on the nail would not have allowed you to flex this, would not have allowed the flexion.
Exactly.
Yeah.
But the nail would have allowed him to weight bear. But I did not think I could get away with doing a nail on this one. So.
Excellent case.
It just looks like a Metallica.
It does. And what's interesting about this is this patient, great kid, but he's a kid, right? And each time he's bugging me when he's going to walk. How long is this going to? And I told him before the surgery, I said, this is a big deal. And I also said, your other option is to get one of those ring things with the spikes. Yeah. So I do think that this is better than a external fixator for him.
Yeah. So this, I think, case is absolutely excellent done, and it really shows you the power of the bony correction. A tibia which is completely subluxed, you bring back the slope, it just comes beautifully underneath the femur. Great case. Thank you very much.
No problem. Thank you.
So,
I mean, the thing that I'd be curious is if you with the PSI templating, if you just did a bigger proximal correction, how bad would it have been without doing the second osteotomy?
I think that that tibial shaft had a big recurvatum deformity, and a big proximal correction was not going to address that. Oh, I also didn't mention, you can't do that without doing a fibular osteotomy. That was the
Correct.
first thing I did, actually.
Yeah, and the other thing would have been that if you would have really gone high with the slope to correct both of them, you would have busted his ACL afterwards. He's
Exactly.
a young kid.
Exactly.
He would have come